Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic.
Bryan was a practicing COTA for 6 years when he discovered that he had an interest in seating and mobility and decided to pursue that practice area. While working as an ATP, he recognized the need for OT practitioners' education and participation in seating and mobility to better serve their clients. And that is why he is here today. So welcome, Bryan, and let's get started.
Awesome. Thanks everybody for showing up at 8 o'clock on a Tuesday. Let's get going. All right. So our learning objectives tonight, you guys will be able to differentiate between different types of wheelchairs, power and manual, determine their appropriate usage for a particular client. You'll be able to recommend postural positioning devices that can be used in conjunction with the seating mobility platform. You'll learn what the role of an OT practitioner is in obtaining seating and mobility equipment. You'll be able to assess the client's physical and functional needs to be able to prescribe the most appropriate seating mobility solution. You'll be able to complete a seating mobility evaluation necessary for obtaining equipment for the client and provide the necessary documentation to support the request. So a little bit about me. I am a COTA. I graduated from COTA school from Bryan College in 2011. Practiced, as Irma said, for about 6 years between skilled nursing and home health. That's really where I got interested in the whole seating positioning and wheel mobility. In the skilled nursing setting, I was kind of the go-to fix-it guy for the wheelchairs, which morphed into now I'm the positioning guy for all the wheelchairs. Home health is really where I saw the need for all of this stuff. Skilled nursing is, most of the residents are Med B, so there's only so much you could do with that. But home health is really where I got to see a lot of the deficits and where a lot of those needs weren't met. Most of the people got discharged in your basic wheelchairs, and it was not a good situation. So that's when I really decided that, okay, this is the route that I want to go. So I sat for my ATP in 2017 and started working for New Motion, their rehab supplier. There's a couple of them in the Atlanta area. New Motion is just the one that hooked me. So I worked with them for, I guess, a little bit over 2 years. Realized that the for-profit realm just wasn't for me. Moved over to the nonprofit world for FODAC, Friends of Disabled Adults and Children. What I'm gonna do a shameless plug now. So what we do at FODAC, we take donated equipment, lightly used equipment, we clean it up, refurbish it however we can, and then redistribute that back into the community for little to no cost. So people are having trouble with either paying their copays for insurance, or they got denials, they can come to us and get that equipment for basically free. I also have done 2 trips to Jamaica to provide custom wheelchairs to children and adults who are in their, I guess, orphanages would be the best way to describe it. And actually that picture up on the screen is me in Jamaica. That little girl lived in a home it was all women. It was run by nuns, and the brothers that would come and help out and stuff were all clean shaven. So I'm guessing she had never seen a beard in her life. And she did that the entire time I was working on her chair. And that's my favorite picture, so I put it up. So real quick, so some numbers and facts about disabilities and stuff. 1 in 4 has a disability that impacts major life activities. That's 61 million people. 1 in 7 has a mobility-related disability. Obviously, over the age of 65, that's going to go up. And the percentage increases as the income decreases, which also is kind of makes sense. In Georgia, 13.6% of adults have some type of mobility-related disability. So what does poor seating and positioning lead to? So obviously it will lead to increased healthcare costs, reoccurring things, pressure sores, orthopedic surgeries. If you're in poor seating, pressure sores are probably going to be the most prevalent. Your orthopedic issues, if scoliosis, any of your contractures could get worse, that kind of stuff. So it's always going to end up with surgeries to try to correct those things that may not have been completely prevented with good seating, but at least slowed down. So, and all of those increased healthcare costs came out at about $10.2 billion in Georgia. This was in 2018. And that's the 26% of total healthcare costs for the state. There's also an increased risk of developing comorbidities, so breathing issues, digestive urinary issues. If you got that bad positioning, then you're crunching everything down. No bueno. And then obviously a decrease in function and independence. So in this picture was also Jamaica. We were walking around, we were kind of done for the day, and we saw this girl sitting there. The leg that is in the arm trough is actually her left leg. It goes underneath her right leg and out the side. So this was not a good situation. Actually, before we left, we went around again, and they had her in bed, and she was sitting up in bed perfectly straight. So obviously, we haven't been back because of COVID. I didn't go back last year for other reasons. We haven't been back this year because of COVID. So, but our intent was to address this when we got back, and we just haven't been back. So why is positioning important to function? So it's really common for people, especially your higher spinal cord injuries. They'll use those compensatory positions and movements to help stabilize them so they can actually do other things. If you move somebody just a little, the slightest bit, it could mean the difference between dependence and independence. Positioning accessories can either promote or inhibit those positions or movements. A lot of times with CP, the older that person is with CP, they've learned how to use their tone to accomplish certain things. If you put a positioning device in a certain place where it inhibits the use of that tone, now you've created a dependence for them. Like I said, a little as about a half an inch can make a difference. And sometimes that person using those positioning devices, if you can use that to promote that movement that they're trying to achieve, then they won't be as fatigued trying to hold that position to do the things that they need to do throughout the day. Again, another picture from Jamaica. You can see in this picture, this chair just absolutely didn't fit this kid. It completely swallowed him up. So you see he sits off to the side a little bit. That's just because the chair is so big, it gives him no support. The wheels are way far out, way far back, so he had a really hard time pushing it. His heels aren't supported, so his legs are tilted down, which is going to pull him out of that chair. So we got him one that fit him really good. And as soon as we got him in there, we had a hard time taking this picture because he took off on us and was rolling all over the place. So why do we need more OTs? Function. So PTs are really good at the positioning side of things. I mean, you get the PTs who have been doing this for decades, and they get the whole function side a lot better. But us as OTs, this is what we do. We look at the entire body, we look at the entire lifestyle of that person and try to figure out what's going to be that best fit, right? As an ATP with New Motion, the majority of my evaluations were done with PTs. And it was good. And like I said, the people that have been doing it for years, they would look at the position of a joystick or things like that. But every single time I was like, man, I wish I had a OT here just so we could do these little other things that maybe they would see something that would help this person be just a little bit more independent in their seating. The other thing is the patients are going to see you as a resource and an advocate. And especially in OT, because we're so involved in every little aspect of their lives of how they're going to be doing things, that's what we need to focus on with the seating and everything. So we definitely need more OTs in this field. So as far as the team goes for getting equipment, so the doctor is the top. When you're getting a referral for a seating and mobility evaluation, the biggest thing, and I'll probably say this 5 or 6 times tonight, make sure the doctor does not put a specific piece of equipment on that order. If they write on there, yeah, they need an evaluation for a hover round, you're stuck getting that person a hover round. So the ATP and the OT and obviously the patient and all those people, they need to be the decision makers on what equipment that person gets. The doctor is, they can recognize that, okay, yeah, they need some kind of help with something, but they don't have all that knowledge that everybody else in the equation does. So like I said, what they say goes. So we want to make that script as vague as possible. So your ATPs, they're going to be your funding and equipment experts, right? So as long as you guys can recognize a need, you don't have to know every little piece of equipment that's out there, what manufacturers design it this way, what manufacturers design it that way, and what piece of equipment is going to get funded and what's not, and all that stuff. That's the ATP's job. Basically, what you guys need to know as OTs and COTAs, I'll get into that too. You just do what you do every day. You're going to see somebody, you're going to assess their need, you're going to make goals. Your goal is to get them independent with their real mobility or better positioning to help prevent further injuries. And then you proceed with that goal. And then you have the patient and the family. Now, I put them last. They are definitely not last. They are the cornerstone of all this. I, as an ATP, wanted as many people who were going to be involved with that equipment and touching that equipment there as I could get. A lot of times you're seeing somebody in a seating clinic and it's just a 1-hour thing. I always wanted as many people there, as many therapists, as many family members there as I could get, because that gives me the most input so that we can make the best decision for that person. So some of the steps for obtaining equipment. So like I said, you recognize the need. Okay, this person is kind of sitting kind of weird. Maybe their chair is old and broken. So, or maybe they just need an adjustment in the chair. Maybe they only need, maybe the frame is okay, but the seating is off, and they might need just new components for that seating, or they might need a whole new system. That can be determined by the ATP. So as long as you see, hey, something's not right with this, call your ATP, whoever it might be, and say, hey, something's not right. Can you just come and take a look at this, and we can go from there. If the ATP says, well, no, we need to do an eval, blah, 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 yeah, might find a new ATP. After all that's, after you figure out kind of what you're going to need, then get a hold of the doctor and get that script for an evaluation. After that, you do your eval with your ATP, and then the ATP takes all that information and puts it in for insurance, and hopefully everything goes smooth. Any questions? No? We good?
None, and we're not bored.
Okay. Because as you can see, now I get all nerdy. Equipment, yay. All right, so your K1. So I put these all in their K codes because that's how the ATPs are going to refer to them. So your K1s are just your basic run-of-the-mill hospital chair. They're heavy. They're not adjustable. They're meant. Everything on this page is meant for temporary use only. It is not meant for a full-time user. So they're going to come in very just basic standard sizes. You're going to get 16 by 16, 18 by 16, 18 by 18, somewhere in there. Seat heights may vary a little bit, but for the most part, it's just a basic chair. K2s, same thing, just they're a Hemi, so they sit lower so that a person can foot propel. K3s are going to be lightweight, so they're going to be lighter than your K1s, but still not adjustable. You got adjustable foot plates and armrests and that kind of stuff, but your axle isn't going to move, none of that stuff. Again, totally temporary. So here we get into the higher end chairs. Your K4 high strength lightweight, so it's obviously going to be lighter than the K1 to K3s. You can get totally custom sizes as far as the seat width, seat depth. They go in usually inch increments from 14, usually all the way for width for adults from 14 to 22. Some will go bigger if they offer a heavy duty model of that. That's another code, but for seat depths, you can go probably the same, about 14, about 20 deep, I think is the biggest they get. These are going to be this is where it starts for your full-time users. So your K4s are typically going to be a folding chair. They're going to be stronger than the other ones. So obviously high strength, lightweight chair. The axle is going to be, they're not going to be as adjustable as the K5s, but you can set it about an inch in front of that back cane. So you're going to have a little bit better center of gravity. That's going to get you better propulsion, better for getting over obstacles like door jams and stuff like that. It's easier to get that front end up because you've got more of the weight over the axles rather than over the casters. The K4s are going to come into play with Medicare. Medicare runs all of their seating by diagnosis. They don't care about anything else. It's if you have the right diagnosis, then you can get the equipment that you need. So people with like diabetic neuropathies and stuff like that, those are the guys. If they wouldn't qualify for a K5, I'd put them in a K4, just because it's the next best thing. So, and then your K5s is your ultra lightweight manual wheelchairs. So this is, again, full-time users. These are going to be your totally independent, going to work, transferring in and out of a car, all that stuff. Mostly spinal cord injuries. This is what you're going to see them in. A lot of people call them sports chairs. Please don't call them sports chairs. Sports chairs are completely different. So these are going to be obviously super lightweight. Most of the frames are going to be around 10 pounds. Your total weight probably somewhere in the 20s. Depends on the seating system that you're going to get. Obviously, some cushions are heavier than others, and the backs are going to be heavier, and blah, blah, blah. We can get into that later. The big thing to remember is that your K4s, K5s are for full-time users, right? Remember that. All right, some of the other wheelchairs, tilt and space wheelchairs. These are going to be for dependent mobility. They do offer these with your bigger 22, 24-inch wheels for self-propulsion, but they sit so far back in the frame that it's not even worth it. So this is going to be for people who can't do their own weight shifts. It's the whole point of a tilt and space chair, is to offload that pressure from the buttocks onto the back, so you can get that blood flow back into that soft tissue, so that you don't end up with pressure wounds. A lot of the tilt and spaces have moved to that rocker system, so you tilt actually on your center of gravity, which makes it way easier for the caregiver to tilt that person, because it takes their weight out of it. It used to be they would have gas shocks in the front, so that you would actually have to push the front end of that chair up, which you're pushing all the way to that person up. So a lot of them have gone to this center of gravity tilt system. For kids, we got stroller style wheelchairs. So this is obviously, it's going to be dependent mobility. There's tons of different options out there. I should reiterate, I have no affiliation with any of these companies. I'm not getting paid by anybody. It's just examples. Convade is probably your most popular strollers for the bigger kids. They're a little bit sportier. They look kind of more like a regular stroller, and they fold up like an umbrella stroller. So they're super easy for parents to get in and out of the cars. The problem with them is that they are typically a secondary chair. So most of the time, unless you got a kid that's going to be their primary chair, you're not going to be able to get these for somebody. A lot of parents use these if the kid has a power chair that typically will stay at school because they don't have the means to get it home to transport it back and forth, or their home isn't accessible for that power chair. So they'll use these to get them back and forth, because it's super easy to load in and out of the car, get them to doctor's appointments, all that other stuff. At FODAC, we run through these like crazy, because, as I mentioned, they're not covered as secondary equipment. And the one on the right, they do have, that's a Convade. Sunrise Medical has a Zippy Voyage that's made for basically birth to about you might be pushing it at 3 years old. Total support system. The whole seating system comes off of the base, and the base folds up. So that's going to be your early intervention strollers. You can on those put oxygen tanks, vents, suction trays, all that stuff. You can attach all that equipment to those strollers. All right, into power chairs. So group 1, group 2, that's how Medicaid does it. So again, this is how your ATPs are going to refer to these things. So group 1s are going to be just your scooters and power operated vehicles. Really, really, really basic chairs. They're like the K1 to K3 of power chairs. So again, not your full-time users. These are going to be the people that can maybe ambulate short distances. You got to watch that on your evals, because again, Medicare doesn't care about anything outside the house. Everything has to be related to inside the home. So somebody who's just having falls in the house can walk short distances, but is going to need something for maybe getting from the bedroom all the way out to their living room or kitchen or whatever those long distances are. They're not very powerful. They're usually pretty transportable. A lot of the scooters will break down into like 3 or 4 pieces, and you can fold them up and put them into a trunk. They're going to be super standard sizes. Again, you're going to have like 16 by 16, 18 by 16, usually always a captain seat. You can't put any other seating on there than what comes with it. Group 2s, you're going to have a little bit bigger batteries, better stable. The bases are more stable. Wow, it's late. You're going to have a little bit faster speeds out of those, and you can a lot of the times they'll come with the captain's seat, but you can get just a seat pan. You can do more custom seating on them if you need to. Group twos are going to be, again, for your people who don't qualify for those group three chairs that we'll get into in a minute. So, like, again, your diabetic neuropathies, a lot of those people ended up in group twos just because they don't qualify for group threes. You can get power tilt on some group twos, which will help with the edema that a lot of those diabetic neuropathies have. Almost every one of them, that's what I would get for them because they had the edema, so you could tilt them up. Some of them you can even get power legs on, so you tilt them back, lift those power leg rests up, and to help out with that edema. All right, group threes. These are going to be your K5s of the power chair world. So full-time users. You're going to have the better speed, bigger suspension, bigger batteries. You can get full power seating on them. You can get all your alternative drives on these. You have front wheel, mid wheel. There are still some rear wheel drive options, not very many. Most of them have gone to front wheel drive, mid wheel drive. The difference between front wheel drive, mid wheel drive. Front wheel drive is going to be a little bit more intuitive for driving. If you're kind of going, if you have a lot of turns in your house, you want to go for front wheel drive because as you get through that doorway, you can cut immediately. You could start to turn and that back end will swing around and follow you. If you just have small spaces in your house, then you want to go with the mid wheel drive because it turns on itself. Its turning radius is basically the size of that base. Those were kind of my deciding factors when I was in ATP of kind of which way to go. You can see there the Permobiles, and I think a couple other manufacturers are starting to do this. They have what they call active tilt. So it's a front anterior tilt. It's basically just for active reaching, help people get to cabinets and that kind of stuff so that they're not having to lean forward out of their system. It'll usually come with those knee blocks if they get more degrees of that anterior tilt. Group fours, good luck getting these funded. So these are going to be your fastest chairs, and these are going to be your standing chairs. I never got a group four put through, and I was really good at documentation. They are really, really hard to have insurance pay for. Usually if there's like a professor or a lawyer, they'll usually get these covered because it's part of their profession to be able to stand up and engage whoever they're talking to. So that's what group fours are going to be. Group fives are all pediatrics. So there's a ton of different ones. And these just happen to be all Permobil. So Permobil just came out with that early intervention power chair, which I absolutely love. Since I got into this, I've been an advocate for getting kids into some type of mobility device, whether it's manual or power, as early as possible. And this is a huge, huge fight with parents. Immediately they say, no, I want my kid to walk. I want my kid to walk. I want my kid to walk. And that's fine. I want your kid to walk too. But in the meantime, they need to be mobile and independent. They need to be able to explore. They need to be able to develop as close to a non-disabled child as possible. And the faster you get them into a mobility device, the easier that's going to be for them. And it used to be, the train of thought used to be, well, we can't give them power mobility until a certain age, until they're cognitively ready to drive. That's not true. I when I was at New Motion, we had a kid that was born no arms, and his feet were basically on his pelvis. And he was able to kind of scoot around with his feet around the lobby and stuff. And they actually put him in the floor sitter chair all the way to the right. Our guys in the back built a little platform, and they had for right under the seat, they had a platform with a little micro joystick. We took him out into the parking lot, and within about 4 minutes, he was driving that power chair, 18 months old, driving it with his toe. So that whole thing, kids are super adaptive. So I was ecstatic when I saw Permobile came out with that early intervention one. So they do have standard style power chairs. They look like your regular adult power chairs. They do all the same stuff. It's just tiny for kids. And you have your elevating chair. So it's a lot easier to get a seat elevator covered for a kid than it is for an adult. You can argue I've gotten it done for adults, but for a kid, it's super easy. So what that's going to do is going to put them at a level to where they're engaging with their peers eye to eye, right? Or even going through a crowd. You don't want them sitting, whatever 15 inches off the ground. They're going to get lost. So they can raise up and they can be seen. People can see them and all that other stuff. The floor sitter. So that's going to do almost the same thing as the elevator. So it's going to get them up into eye level, but it also lowers them all the way down into the floor so that they can play with their peers, so they can engage socially. All right, cushions. So your general use cushions, typically going to be foam. These are going to be, that category is going to be the same as the K4s or the Group 2s. It's under Medicare. If they don't have a diagnosis that qualifies them for a higher grade cushion, you're going to get stuck with a general use cushion. So typically these, they're always going to be foam. Typically you're going to find them like those standard drive cushions that are just your regular foam. Axiom is Key Mobility, I think, owns them. They're the only ones that I could find when I was working as an ATP that had a general use cushion. Comfort Company has one, but it has a sacral cutout that not everybody needs. Sacral cutout's going to develop, you're going to end up with more pressure issues on the outside of that sacral cutout. These guys, they use that honeycomb pattern to help distribute that pressure under the ITs, and it has that kind of an offloading, that indent to help offload some of that pressure. So that was my go-to for general use if I couldn't get them qualified for the other cushions. Words are hard. So your general foam cushion, if you get into your better cushions, so you can even custom make a cushion. So there's tons of different types of foams. There's tons of different densities of foams. So you're going to have positioning and pressure relieving features on these foam cushions. So the positioning is going to be your more contoured. You can, like I said, you can custom make these. So if they have like a pelvic obliquity, you can do a cutout on one side, or you can overfill one side, or raise up one side, whatever needs to be done. These are typically going to be so for someone who has no threat of skin breakdown. So if I had somebody young, active, did their own pressure relief, they never had a history of skin breakdown, they were continent, all that stuff, I would just go ahead and put them on foam. Gel is going to be your next step up. So you're going to have obviously better pressure distribution with gel. It's obviously going to have more maintenance than foam. Foam, you don't have to do anything to maintain it. The big thing with gel is anytime anybody gets out of that chair, they have to knead that gel back into place. If they just keep sitting on it, all that gel is going to spread out, and then it's no longer going to work. For people who had a history of pressure sores, but don't currently have a pressure sore, that's who I would usually put gel on, or put them on gel. They're way more stable than your air cushion. Anybody who uses a sliding board to transfer a Rojo cushion that I'll show you in a second is really, really difficult to transfer onto with a sliding board. If they can lift themselves up and plant themselves on top of that cushion, then a Rojo is fine. So you can see that Rojo has these individual cells and they all move around, right? So if you're sliding across it, you're just going to shove all those over, and now you're dealing with shear. The other thing about gel, it's super temperature sensitive. So especially down here in Georgia, we got hot summers, cold winters. So if this thing sits out in the heat, the gel is going to get really squishy. And if it gets cold, it's going to get really hard. So that's something else to think about that. All right, so air. Air is going to have your best pressure distribution, hands down. Not going to beat it. So the whole thing with the Rojos, you want to fill those things up, have that person sit on it, and then slowly let that air out so they immerse into that cushion. The whole thing with pressure distribution is you want the most contact surface area as possible, because that's going to distribute that pressure across that broader surface area and relieve those hot spots. Like I said, really hard to transfer in and out with a sliding board. Anybody who obviously had a history of pressure sores, especially if they're recurring, it wasn't just like a one-time thing where they had an injury and were laying in bed for months or whatever, or they currently have a pressure injury. Those guys immediately onto a Rojo cushion. There's a lot of variety in the Rojo cushions that you can get. You can get them custom contoured. You can make it so if they have a pelvic obliquity, you can get shorter cells underneath and higher cells around and all that other stuff. They are, if you have somebody that's a smoker, try to steer away from a Rojo, because they're bound to drop a cigarette on that thing and they're going to burn it and it's going to get a leak and then they're out of luck. The one that's in the picture is called a Quattro. So it actually has 4 chambers and you can lock those out so that if you get a hole in one of those quadrants, then the whole thing doesn't go. So it saves you a little bit, but you still got a flat spot in there. So something to consider. So the next thing, and I did a ton of these, are the hybrids. These would be really good for someone that does use a sliding board to transfer and has pressure injury history. So it's basically a foam base with either a gel or a Rojo insert under the ITs. So you get that immersion, that pressure distribution under the ITs, where that's typically where you're going to see those pressure injuries, but you get that stable surface to lay that sliding board on for the foam. Backs. All right, same thing. General use backs. So it's going to be your sling backs. They do make hard shell backs for them. The thing is, you're not going to be able to add laterals to them, and it's basically just a support. That's all it is. So your contoured are going to be, you have varying degrees of contoured back. So this is a deep contour. So that's going to help, and it's going to wrap around and move close to the camera. So it's going to wrap around their trunk and just give them that stability. If they have some like scoliosis or any of that stuff, this isn't what they need. This is going to be for like your higher level, thoracic level spinal cord injuries. So they just have kind of that weak trunk control. They just need something to stabilize them. That's where you're going to go into your contoured backs. Planar backs, you're going to see this all day long in pediatrics. So, and the reason is that it's you can get an eye back like what's in the picture. So you can move those thoracic laterals wherever you need them. And as that child grows, you can move them higher and higher and higher. Or for scoliosis, you can offset them. It's basically, they make these to be able to grow with the kid. Once they're adult, I would probably shy away from these, just because there's better off the shelf stuff, not better, more appropriate off the shelf stuff that you can do, that may give a little bit more support. And then custom molding. Custom molds are going to be for your most severe skeletal, musculoskeletal deformities. So if none of these other things are going to work for them, they're not going to give them the support that they need, go for a custom mold. For kids, your best bet is probably a foam in place, just because they're growing and no insurance is going to pay for a custom mold every year or two as that kid grows. They're just way too expensive. That's the downside to them. If it was up to me, everyone would have a custom molded system because it's made for that person. It's exactly what they need. All right, positioning accessories. We're going to start at the pelvis. Why? Because everything starts at the pelvis. Never forget that. Everything starts at the pelvis. So your basic pelvic belt is your 2-point hip belt. So the best way to mount, there's a couple ways to mount these. If they have a tendency to go into that posterior pelvic tilt, you want to mount that belt so that it lays across the hips and catches those ASIS so the ASIS can't slide under that belt. If they don't have that issue, then you could just mount it at that 45-degree angle. Then it's more for just kind of comfort and safety, peace of mind that they're not going to go flying out if they hit a bump. 4-point pelvic belts. So this is going to be for both your pelvic posterior tilt and any rotation that happens. So you're going to lay part of it across the hips, and then one is going to go kind of back, probably at the base of the canes, to help pull that pelvis straight. Seat harness. So your seat harness is going to be for anybody that has that tendency to slide out. So that, again, that posterior tilt, any of those, any extension tone or anything, they have that tendency to push out. Kind of a non-invasive thing. It just kind of wraps around the legs to keep those secure. While I'm on that note, please don't ever use a medial thigh support to keep somebody in a chair. That area down there is not a weight-bearing surface, so don't do that. Lateral pelvic support. So those will go on the seat, on the sides, on the hips. We'd use those for scoliosis support. If they have a tendency to shift off to the side, then just to kind of keep them in that seating system better. That would be your third point of contact for scoliosis. One would be thoracic lateral at the top, one at the curve, and then one at the hip so that they don't push out. Then your sub ASIS belt. So that's just going to have, it's basically your 2-point belt, but it's got little pads that sit on your ASIS. So anybody that's got the catheter, or not so much a peg tube, but colostomy bag, anything like that, where that belt might rub on something and cause irritation, that those pads will hold that belt off away from the body. All right, lower extremities and feet. I go there because that's your next thing. Lateral thigh supports. So same thing kind of as the hip support, but this can run the length of the leg. So if you have anybody that they have severe abduction, we need to control that so they don't bang their knees into a door frame or something. That's what the lateral thigh supports are going to be for. Medial thigh supports. they'll call them abductor pads. The old days, they called them pummels. Again, not a weight-bearing surface. Do not use these to keep people in the chair. I cannot say that enough. So these are going to be, and I'm probably going to refer to kids a lot here because that's what I do now is work with kids. So as kids that they have that high tone, those legs are just pressed together. So this is just going to keep those legs apart, keep those knees from rubbing together and creating sores. Knee adductors. So kind of the same thing as the lateral thigh support, kind of serves the same purpose. It just holds the knees in instead of the thighs. Knee blocks. So really don't use these a whole lot, but it's the same thing as to keep them from sliding out of the chair, just holds their knees in. Calf panel. So a lot of times people will kick those legs back, whether it's tone or whether they're just a comfort thing. So that calf panel will keep them from getting their feet caught in the casters, from getting them back behind the foot plate and breaking a foot. Actually I've seen quite a few spinal cords breaking legs doing transfers, getting their feet caught behind the foot plate and in the casters and everything. So calf panel will help with that. Shoe holders. So this is more of a safety thing rather than any kind of real positioning. Obviously, if they have inversion, eversion, anything like that, you can kind of help mitigate that with the shoe holders. It's basically exactly what it says. It just holds your feet in place. A lot of times, if they have that tone and they end up kicking their legs out and it affects what they're doing, you kind of hold that down. Ankle huggers, pretty much the same as a shoe holder, except they just wrap around the ankles. Maybe you got a kid that can't tolerate shoes and they just wear their socks or barefoot all the time. You use the ankle huggers instead of the shoe holders. Foot boxes, same thing, just kind of, so these I would use typically if they were stuck in that plantar flexion, so we get something soft under the balls of their feet or their toes, so they're not same thing, so they're not getting those pressure injuries. Trunk positioning accessories, thoracic laterals. So talked about this a couple times already. Basically, it's just trunk support, scoliosis support. Chest harnesses. So anybody that's has a tendency to pull forward, whether it's a safety issue or just a positioning issue, there's all kinds of different chest harnesses out there. So you have some that are a little bit slimmer in the mid area for females, so that it cuts around, so it's not pressing on you. The one to the right is the H harness, so you could just clip it out and it comes off easier. They have ones with zippers in the middle, all kinds of different stuff. If you have somebody that it's just a shoulder postural issue, I would actually go with the shoulder straps instead of a full chest harness. I wish that I had done more of those. I had a lot of the old school PTs that I was working with. It was automatically to a chest harness, and I wish I would have pushed a little bit more for the shoulder straps. Way less invasive, especially if you have a kid that's sensory like me. You can probably see me twitching and stuff. That chest harness would drive me nuts. So just having that on my chest all the time. Another thing with the chest harnesses, so you can either get a static one, so it's usually like a pleather, but it won't stretch at all, so they're just kind of stuck in their chair. The ones that are there are neoprene, so it gives you a little bit more movement. Then you got chest strap, so a lot of the time buses, bus drivers want all this stuff on the chair to help protect the kid. If they don't necessarily need a chest harness, we'll usually just do a chest strap just to kind of, so they can get on the bus to hold them to the chair. Again, less invasive than a chest harness. So if it's more of, they're not falling forward, but maybe they push out, that chest strap will help with that. Went over the shoulder straps. Shoulder positioners. Not a ton of these out there. So basically the same thing, but it's just a rigid device to help hold those shoulders back. Upper extremities, your arm troughs. Arm troughs are arm troughs are arm troughs. So a lot of times you'll strokes with sublux shoulders. They'll throw these in there just to give that extra stability on that armrest to help keep that sublux shoulder in. A lot of times we'll use these with quads and power chairs. So as they tilt back to do their pressure relief, if they don't have those arm troughs and the lateral and the posterior arm supports, those arms are going to fall off the armrests, and now they can't reach their controls to get back, right? So these two arm troughs, the really padded one, you wouldn't use that for like a quad. That would be typically for a stroke patient with a sublux. They also have arm troughs that come with all kinds of different hand pads. So you can get like a resting hand pad and one with a knob in it so they can grip. And there's all kinds of different ones out there. Oh, there they are right there. Ha! So they make the wings adjustable. They have metal in the side, so you can bend them in or out depending on how big the person's arm is. Trays. So trays, again, so you would have somebody prop up on that tray to help support them, support their posture. A lot of times the tray is just used to do schoolwork, and you set your iPad on there or your laptop on there and do that kind of stuff. But to get it funded, it's an upper extremity positioning device. Then your posterior lateral pads, again, same thing. Usually on a power chair or a tilt in space where the kid is, if you tilt them back, the arms are going to go. All right, I got to take a drink. All right, so your headrests. The reason I put the Comfort Company headrest up there, and again, there's tons of headrests out there. I really like that butterfly shape because it'll cut under the ears, give you that cervical support and the lateral. There's, depending on which pad you get, they have bolts in the side so you can swing those wings in and out. Whitmire also does that. The thing that I didn't really like about the Whitmire is just an oval pad, so it has a tendency it'll sometimes hit the kid in the ear, hit the person in the ear, which over time could develop some skin issues back there. Mostly for tilting, so it's just somewhere to put your head, so when you tilt back, your head just doesn't go flying off the chair. Cervical positioning, so Stealth is the main one that kind of makes these. There's a couple other companies that make them, but this would come around the neck, so you get this, so you get the lateral kind of support as well, and then just a pad in the back. Cervical shoulder positioning, again, Stealth. So the one on the left is it's called an eye to eye. So anybody that has that anterior drop, I've had a couple therapists that want to do the head strap that we'll get into. I always went for the eye to eye because it has the chin prompt on it. So you get all the support here that you need, so laterally, posteriorly, and then you get that chin prompt to hold the head up anteriorly. The problem with the head strap is that now you have one point of pressure and you have a head that wants to go forward. So you end up with this thing going on, which doesn't help anything because that's going to close off your throat anyway. So you're not going to be able to swallow right. You're not going to be able to breathe right. I always went with this. The other one is a Danmar. Does kind of the same thing. So it's basically a soft collar. They do have them where they have metal stays in there so you can adjust everything. Then your anterior head support. So the one I have the picture of is a little bit better because it supports the back of the head. Yeah, I don't have just the regular strap. It supports the back of the head, so it kind of keeps you tucked in a little bit better, but you could still have that tendency to fall out of it. Again, not a huge fan of them. Lateral head supports. So you'll see these a lot in power chairs, especially for head controls. They'll put proximity switches in there so that you can turn your power chair with them. They do okay as head supports. Again, if you're leaning really hard on it, you got a chance of getting some skin issues there, or even bringing around like that. So they have their uses, and it's a very limited demographic that's going to need those. But it's good to know that they're out there. All right, any questions? We're already an hour in. Wow, it's going pretty good.
No questions that I see in the chat box,
No.
but if you do have questions for the chat box, write them in.
All right.
All good.
All right, we will move on. So the eval. So when is it time for the seating and mobility eval? So if you know they're going to be a full-time wheelchair user, say you're in skilled nursing and they're going home, you're in acute rehab or any of those settings, and you get a new injury and you know they're going to be a full-time user, please do not send them home with a K1 to K3, because I will hunt you down and I will beat you senseless. It's just not appropriate. So if you know they're going to be a full-time user, you know they're going to be using that chair for their mobility, get a seating mobility eval done with an ATP. If you have somebody that's already in a chair, and say you're an outpatient rehab, and they're coming in and I got pain here, and I got, this is bothering me more, and this is bothering me more, and they're having postural changes and some other changes, it might be time for either a whole new system, maybe just a seating system, something along those lines. Call your ATP, say, hey, I need you to come take a look at this person. Something's not right. Can we figure out what we need to do? Obviously, development of skin issues, if they've never had skin issues before and it's not contributed to some other factor, incontinence or anything like that, then we need to reevaluate that seating system. And then obviously, if they've had a chair for umpteen years and the thing is falling apart and it's just not cost effective to keep repairing it, then it's time for a new chair. Okay, so never do an eval without an ATP present. Medicare requires an ATP to be at that eval. 90, like any other profession, 99% of the ATPs out there are in it for the right reasons. They want to help out. They want to do the right thing. You're going to have that 1% that's in it for the money. So if you call somebody and say, hey, we need to do the seating eval, and they say, go ahead and do the eval, I'll see them at their house, get a new ATP. You want them there. They need to know all the information that you know about that person, right? Okay, off my soapbox. So first, ATPs are the equipment funding experts, right? So you don't need to learn the ins and outs of every piece of equipment. You just need to know basically what we went over. What does what, and what is going to help somebody out. And use their knowledge. They've probably been involved in a lot more evals. Unless you're a dedicated seating clinic therapist, then the ATP's probably seen their fair share of stuff. And ask them questions. To the last point, this is your eval. If there's something that the ATP recommends and you have questions about it, bring that up. Because a lot of ATPs have been doing this for so long, they, like anybody else, they kind of get into this routine just because it makes it easy. It's, oh, well, this person has this, we'll get them this equipment, this with this, and this. And that, I mean, it'll change by person, the specifics of it. But if ever an ATP is trying to push something, ask why. Why do you want to do that specifically? Just because this is your patient, this is your eval, these are your credentials. If you don't agree with it, you need to speak up and tell them that. Yeah, totally lost my train of thought. But yeah, stand up for the patient, stand up for yourself. Don't let an ATP bully you into some piece of equipment that you don't think is right. All right, so for your documentation, you always have to rule out lesser equipment. I know it's going to seem completely redundant that someone who's an amputee who doesn't have prosthetic legs yet, obviously they're not going to be using a cane, crutches, or walker because they don't have legs. You still have to write that down. Here's why they can't use cane, crutches, walker. Here's why they can't use a K1 through K3. Here's why they can't use whatever it is. If they need a power chair, here's why they can't use a manual chair. You have to rule out everything else and why you came to the decision of what you came to. So your eval is going to be the opposite of a progress note, right? So our daily documentation is, hey, here's where they're shining. Here's where we're progressing. Here's what we still need to work on. Your eval, I've told every single patient that I ever saw, I want to know you on your worst day because that's when you need this equipment the most. Ego, especially if you're, as an ATP, you're only seeing these people for however long that eval is, right? And if you're running a seating clinic as a therapist, you're only seeing them for that hour or whatever that eval is. If this is somebody you've been working with, you know all those ins and outs. So I had a lot of times with those quick evals, that ego comes in. So how do you transfer? Well, I used to be able to, I don't care. I need to know how you transfer right now. I need to know what your strengths are right now. I need to know what your weaknesses are right now. Yeah, you want to know what their worst is. A lot of times, especially in pediatrics, if a kid either autism, CP, any of those, the parents, if they're coming in for that eval, they will drug the crap out of those kids so that they sit still for the eval. That's great and wonderful, and it makes everybody's life easy. But then the ATP goes to deliver that chair, and that kid is all over the place, and nothing is going to fit right. He's going to bang the backrest, and it's going to destroy the canes and all this stuff. And the ATP sitting there going, this is not the same kid we evaled, and all this equipment is now inappropriate. That's a big battle. So if you are working in pediatrics and you know you're going to be doing an eval, tell the parents, look, just bring them in like it's any other day. Do not do anything different. We need to see these people at their worst, because that's when they need the equipment the most. Okay. We all got taught 90, 90, 90. You're never going to see 90, 90, 90. Chances are you're sitting watching this right now and you are not sitting at 90, 90, 90. I'm not, because it's uncomfortable. It's great. It's a great ergonomic position. And a lot of times you're going to see people, especially if they're nonverbal, they can't tell you that they're uncomfortable. Chances are they're probably dependent as well, maybe not. but they're not going to be able to shift and move and get out of a position that's uncomfortable. While I was at FODAC, I had a kid come in and CP, nonverbal, and got him in a tilt and space chair, and it was sitting, the back angle is 90 degrees. Get him in the chair, and his arms went straight back. Big smile. And everybody there was, oh, he loves it, he's smiling. And the first thing I thought was, nope, something's wrong. And it was just that body position, and it was that, and so I took the chair back, I opened the back angle up about 10 degrees, put him back in it, and he relaxed. I was like, that's it, that's what it was. OTs, PTs tend to see that stuff. OTs, we can kind of catch that a little bit easier, which is why we need more OTs. So watch for that kind of stuff. Yeah, so 90, 90, 90. And of course, I put a picture of our girl there flicking everybody off. So yeah, the chances of actually getting somebody to sit 90-90 is very, very slim. They're going to sit where they're comfortable, where they're stable, where they can perform their ADLs easily and independently for them. Okay, so the eval form. I used the Houston Methodist for every single wheelchair evaluation that I did. It was developed by an OT at Houston Methodist to satisfy the Medicare algorithm. Didn't matter, because it was so comprehensive. I used it for every wheelchair eval, from kids all the way up. Yes, it's 16 pages, but the last 8 pages is all equipment. And so you can just go through and check what you need and all that stuff. As I say, it's a good template. It has a lot of information, but the interview that you do with that patient is going to give you way more information. Any of that extra information, there's a section, the last page is a paragraph, a whole thing where you can write up a paragraph. Use that. That's where you want to tell the patient's story. That's where you want to say, here, this is what they do every day. This is why they need this equipment. This is why the other stuff isn't going to work. And that's where you get really specific about stuff. It doesn't need to be a novel. It doesn't need to be, unless you're really fighting for something, then you want as much documentation as you can get. If you have qualitative tests that you did, put that stuff in there. Again, as you do more evals, you're gonna notice, oh, I didn't ask them about this, and that would make a big deal. And you're always gonna find more stuff than what's on that form, but it's a good base to start with. The link there is to New Motion's website. If you go there and just type in the search box Houston Methodist, you'll be able to find it. I don't know that it's anywhere else on the internet besides New Motion's site. Don't quote me on that, but I'm sure you can find it online. Okay, so for the interview part of the eval. Again, you want as many people there as possible. All the caregivers, anybody who's going to touch that equipment and use that equipment, obviously the patient. So if they have like nursing staff or as many of those people as possible, because how that equipment is going to be used is going to determine which direction you go. It may even determine what manufacturer you use. So, and you want to ask about every aspect of their lives. A lot of times when you're talking to somebody during an eval, they'll leave out huge portions of their day. A lot of times you'll talk to somebody and their caregiver, their spouse, or family member is sitting behind them. I laugh because I've seen it. And they'll tell you something, and the person behind them is going, no. So maybe they tell you, oh, yeah, I can do that by myself just fine. And the caregiver is going, I have to pick them up and move them or something. So there's many people in there. Talk about their day in depth. Find out what they're doing day to day, where they need help, and how that equipment is going to help them do that. Diagnosis, you want primary, secondary, as many diagnoses that are related to that equipment as possible. Knowing that diagnosis before the eval, if you're just doing a blind eval, is going to get you at least an idea of what that person is going to present like. We all know that everybody's different. No matter if they have the same diagnosis, it's going to present a little bit different for every person. But at least get you in the ballpark, get you in that frame of mind of, okay, so it's a spinal cord injury. We're kind of probably be looking at this and doing this, and you get kind of a game plan before you even start. The diagnosis will also determine the eligibility, especially with Medicare. That's all. That and inside the house use, that's all they care about. Again, starting point for determining. You want to know about when their diagnosis started. So if they're a spinal cord injury, how long ago were they injured? If they're a new injury, you want to allow for some change in that seating system because their body is still adapting to that new, how they do things. And you're going to have settling in their posture and just little slight changes in their posture and how they're going to move their body and stuff. So you want to allow for a little bit of adjustability in that seating system for those things. You want to know about the prognosis. So ALS, MS, any of those things that are going to continue to progress, you need to know that. So say ALS, they're just getting to the point where they need to start using a power chair. You need to make sure that that power chair is a group 3 and has the ability to keep adding on more features to it, because eventually they may end up with a head drive unit or a sip and puff or even eye tracking. So that chair needs to be able to adapt to all of those systems. Any surgeries, any of that stuff you need to know. Again, is it stable, progressive? Is it exacerbated periods of remission? Like MS sometimes will flare up and then go away. So you need to anticipate for those flare-ups. When are they going to need? What do they need when that is at their worst? Again, medical history. So medications. I talked about this with the kids. So any of those medications that say they take pain meds, is that going to make them dizzy? Is that going to somehow affect how they're going to be using stuff? Bowel bladder function, are they continent, incontinent? That's going to come into play with skin integrity. Again, surgical history. Past surgeries, yeah, okay. Future surgeries are the big one. If they have scoliosis, say you're designing a back to help accommodate for that scoliosis, maybe a month and a half down the road, they're scheduled for surgery to have rods placed. That throws your whole thing out the window because they're not going to be the same person afterwards. Cognition. So can they use the chair independently? Do they have the cognition to self-propel? Do they have the cognition to, if they're in a power chair, to stop that power chair if something runs in front of them, like a little kid? You're talking about a 250-pound chair plus the person. So that thing can do some damage. The stroke, do they have that neglect? Are they going to veer off into a wall with that power chair? Any learning deficits that you may have to tackle for teaching how to use that equipment, right? So the analysis of all the body systems. So pulmonary, can they self-propel over a long distance, right? So that might be the determining factor between manual and moving up to a power chair. Maybe, yeah, they can push their manual chair around their house for all day long, but come, dinner time, they're exhausted and they can't cook their meal because they're too tired, and they just end up going to bed at like 5 o'clock and they don't eat again until the morning. So, or a power chair would let them get through their day with that amount of energy that they need. Cardiac, same as pulmonary. Can they make it through their day with what they have? Tone spasticity is controlled by meds. A lot of times with the kids, you see it with the medication. Do you need to control that tone, or do you need to accommodate for that tone? The big one is that extension. Anybody that's worked with a kid with CP, tone tone and strength are two completely different animals, man. You do not know strength until you've seen a kid's tone kick in. They will destroy a chair. If that tone is really bad, you can add in dynamic systems into that seating to help take some of that shock off of those components so they don't destroy that chair within 6 months. Any edema, with their arms, legs. So make sure you take that into consideration for your seating system. Maybe they need the tilt. Maybe they need their arm troughs to be able to raise up. Bowel and bladder, same, skin breakdown. Vision, hearing. If they're rolling down the street, can they hear a car coming? Can they see everything so they don't run into stuff? Are there accessories to help compensate for that? Again, pain, can it be relieved by postural changes? So if they're sitting up for a certain duration, will that tilt help them? Maybe they have lower back pain, and tilting back kind of takes that pressure off from that gravity kind of pulling on them. Something to consider. And obviously skin. Lifestyle assessment. So your MRADLs, we all know ADLs. These are your mobility related ADLs. So what activities do they participate in from their mobility device, right? So their home environment, again, it's all Medicare cares about, but you need to know, is that home accessible for that equipment? There's no point in getting them something if they can't use it, right? I can't tell you in home health how many times I saw a group 3 power chair sitting in the corner as a clothes hanger. Either they couldn't get it in and out of the house, so it just kind of sat because there's no reason to really use it just in that small space that they were in. Any of that stuff. So it's just, yeah, you don't need to do a home assessment. ATPs will go do a home assessment, but definitely ask a lot of questions about that. Outside environment, even though Medicare doesn't care about the outside, are they going to be taking that power chair out to their garden to go pick vegetables? Are they going to go to the park with their grandkids? Are they going to take the kid out to the park? All that stuff needs to be, so you need to be looking for maybe something a little bit beefier, a little bit more stable. Size and weight, do they have big weight changes? So your body types, diagnosis, growth, spina bifida versus CP. So you're going to, based on those diagnoses, you kind of have an idea of how they're going to grow up. Spina bifida, their legs are probably going to be a little bit shorter. CP, they're probably going to be tall and thin. So just some generalizations. Again, everybody's different. Everybody shows different, but some generalizations there. Current equipment, what do they have right now? What do they like about it? What don't they like about it? I've had a lot of people that we've actually changed complete chair manufacturers because they're like, okay, well, everything about this, it just keeps breaking and we just need to try something else. So, and then you talk about their individual goals. Okay, so what do you want to be able to do with this equipment? Maybe it's a new injury and they want to get back to work. They want to get back to doing other things. All of that stuff needs to be taken into consideration. The physical assessment. All right, so you can stop staring at the picture. So this isn't as bad as you may think. It's all stuff that everybody's learned in school. So your muscle strength, your MMT, you're going to do it for every part of the body and all your major muscle groups. Don't forget about hand and grip strength. So that could determine whether you need just a standard push rim, a rubber coated push rim, one with protrusions, or maybe you need to go straight to power. And that could determine the joystick for the power, right? So is it just a regular joystick? Do they have the dexterity to use just what they call a carrot joystick? So it's just a standard joystick that you've seen. Do they have less control? Can they have more of a gross motor control, where you use they call it a field goal control? So your hand sits in it, you can just drive like that. All that stuff. So trunk and neck strength. So do they have that strength to keep their head up, or do you need more supports? Motor control, motor planning, muscle tone, obviously increased tone or decreased tone. Do you need to accommodate for it? Do you need to promote it? If you put that person in a different position, does that tone kick in? Is there certain positions you need to avoid because of that tone? Any of those triggers. So if they go over a bump and that tone kicks in and then they can't drive, so maybe you need a better suspension on that chair. Do they use their tone for function? We talked about that. Sometimes they'll use that tone to actually be able to drive. So if that joystick is just a little bit off and they're using that tone to be able to reach that joystick and drive, and that's the only way they can do it, if that thing is a little bit off to one side and then they can't reach it, those are the things we got to watch out for. Any primitive reflexes. So the big one is that startle reflex. I have initiated many a startle reflex in my day, completely by accident, because something will pop in my head. Oh, and that person goes, ah! So watch how that affects their posture. If that reflex completely throws them out of their seating system, maybe we need to look at like a chest harness or some other containment device to help hold them into that seating system. Skin integrity again. Do they have skin breakdown? Have they had a history of it? Where was it? All that stuff we need to look out for. Balance, sitting balance, standing balance. Sitting balance is going to be, again, do you need to accommodate for that? Range of motion. So the big thing with that is, especially it's again, could be a determining factor between your power and your manual. Say they don't have that shoulder range of motion, that elbow range of motion to get a full propulsion stroke, then that's going to compromise them. They're going to use more energy throughout the day to get around. So you may want to start looking to that power. You want to go through all that range of motion when you put them both in seating for the Mataval and in supine for the Mataval. So you want to see what gravity does to that range of motion, if anything. All right, the Mataval. So obviously we can't get all touchy-feely because it's virtual. This was supposed to be in person, and I was going to have everybody, feeling on everybody else and doing a Mataval and all that stuff. So we'll just theater of the mind for this. So want to use the firmest surface that you can. If you're doing home health and you're doing or you're doing the wheelchair eval in somebody's home and the couch or the bed is the best you have, then that's the best you got, right? You're not going to have the great therapy mats everywhere you go. So just do your best. So you want to start supine. So why supine? Because it takes gravity out of the equation, right? So where do you start? Pelvis. Always the pelvis. Everything starts at the pelvis. So you start at the pelvis. So you're going to look anterior, posterior tilt. A lot of times with spina bifida, you're going to see that anterior tilt. Left and right pelvic rotation, left and right pelvic obliquities, and then you're going to move down to your lower extremities. So hip flexion, abduction, adduction, knee flexion, extension. So you're going to want, if you find any deformities, you're going to want to document whether they're flexible or fixed. So that's going to determine whether you're going to correct that thing or you're going to have to accommodate for that thing. So like I said, for the pelvic rotation, if it's fixed, then you're probably going to have to do some infill in the backrest to meet that backrest with the PSIS to help support that, so that they're just not out there in space. If it's flexible, then you use that 4-point seatbelt to kind of pull them back and straighten them out a little bit so that it doesn't get any worse. Same thing, obliquity, you're probably going to see that with scoliosis. So if it's fixed with that obliquity, you need to accommodate for that in the cushion. So you need to either, so you need to have a cutout on that low side so they don't have all the pressure under that one IT. If it's flexible, then you may need to overfill that one side to help push that side up. Same thing, hip flexion, abduction, adduction. Whether it's flexible or fixed, you can use those different devices in different ways. Then you move to the upper extremities. So once you get your pelvis set, so while you're doing the Mataval, and this is more for sitting, we're in supine. I'll stick with supine. ADD. So when you're doing supine, you want to have their legs kind of up like this. So if you put your feet on your shoulder, or you hold their lower legs under your arms. So as you move those hips into flexion to test their range of motion, you want to have your hands on their pelvis. You want your thumbs on those ASIS and your fingers on the PSIS, so you can feel when that pelvis breaks. Not breaks, but breaks as far as tilt. So that'll determine, okay, how much hip flexion before that pelvis starts to roll. So that's where you're going to be, your limit for that hip flexion is going to be. Same thing for extension. If they lay flat and that pelvis comes forward, then you know, okay, well, we can only go so far with that. So for the upper extremities, it's basically just going to be, you're going to go through all of it. The big one for the Mataval for the supine is feeling that pelvis, because you're not going to be able to do that when they're sitting. Then the trunk, check for the lordosis, kyphosis, scoliosis, and you'll probably see that more. You'll see the effects of it in seating, but you'll be able to see it in supine. So you'll sometimes I'll have a tendency they can kind of hide it when they're sitting up, but when they're in supine, it'll kick over a little bit more. Head and neck. We still got 30 minutes. So once you get all that stuff done in supine, then you want to move them up into seating, see how that gravity affects everything, right? So you want to get that, and this is where you want to get that ATP involved. So typically, when I was at ATP, I'd have the therapist sit behind the person on the mat, and you get the pelvis adjusted where you need it, and then you give them that support for the trunk. What this is going to do, and have the ATP kind of position the lower extremities where you need them so that their feet are flat, and they're as close to 90-90 as you can get them in that good seating position, and that way you can see where those tensions are, right? So if they have any kind of tightness or anything, you can feel where that's going to be. big time with the scoliosis. So you can put your hands, even if it's a little bit flexible, you kind of cup your hands where you need to see how flexible that's going to be. And that's going to give you that feel of how much pressure you're actually going to need to put into those laterals to help correct that. Or if it's so much pressure that you know that they're going to be leaning on that lateral so hard that they're going to end up with skin issues, then you need to kind of think about something different. When I would do evals with, I would always kind of jump in because I wanted to feel what was going on too, just because it gives me a better idea. And so I'd have to close my eyes to see with my hands, and it kind of freaked everybody out. They're like, what are you doing? Why are you closing your eyes while you're touching them? That's how I see. So yeah, your hands are going to tell you everything you need to know about that person's body and what it's doing. So get your hands in there. So again, start at the pelvis. Make sure that pelvis is stable and where you need it. Right. That's your base of support. All your stability starts there. Then you're going to move to your lower extremities. So once you get that pelvis set, just kind of see what they do. Move a little bit, see what they do, move a little bit. When you get it to where they're stable, then move to their legs. Find that position to where they can still maintain that stability. And then move up to the trunk. And then your upper extremities. So maybe you sit them up nice, but as soon as you move something, you move their arms a little bit, then they do something weird, right? So you check all that stuff and then move on to the head and neck, because that's going to be the last thing that you need to address. While you're doing all this, when you find that stable place, do some activities with them. Have them reach for stuff. Have them do things to check and make sure that that's a stable position for them. If it's somebody who's like a spinal cord injury, who's used to doing things independently, you could test that stuff and maybe they'll use that shift, that postural shift to help stabilize themselves. That's all stuff you want to see. All right, taking measurements. So typically the ATP will probably do the measurements. If you need to do the measurements, so if you're getting equipment from me at FODAC, I need measurements, especially if it's for a chair. So make sure you use something rigid, a yardstick, a folding ruler. Don't use a measuring tape. If you're doing hip width, that measuring tape will have a tendency to run over. Now you're taking some obscure measurement, not just a direct hip width. I would usually, because I have massive hands, so for like hips and stuff, I would take my hand, set it along their hip, put the yardstick against that one, and then just use my hand and slide it up there, and I could just read the measurement like that. If you don't have massive Sasquatch hands, then just use like a clipboard or a folder or something that can at least give you that plane to be able to measure. If you want the ATP to bring out trial equipment, which I totally recommend, try to at least get them seat width, seat depth, and maybe lower leg length, and maybe back height. So like seat to shoulder, seat to axilla. So those on this would be F, G, I, J, and C. Those are your basic ones that you can kind of adjust the chair around that. Those are your kind of your go-to measurements. That's usually what I ask for at FODAC when I'm building a chair for somebody. Because everything else is pretty adjustable that you can make it kind of fit, at least enough for an eval. Medicaid now, when I was at New Motion, Medicaid started requiring equipment to be trialed, and you had to document that in your eval. I don't know if other insurances are starting to go that way, but it's not a bad idea to include that in your documentation that you, hey, here's what we tried, here's what didn't work, here's what we tried, this worked great, this is what we want. So try to get as much trial equipment as you possibly can to have your ATP bring it to the eval or a pre-eval. Oh, case studies. Yay, you guys get to type stuff. Now we get to see what everybody learned. So the first one, 18-year-old female, new T9, T10, complete spinal cord, currently in rehab hospital, preparing for discharge. She is your patient. You've been working with her. Independent with transfers, most ADLs, no postural issues. What chair, cushion, back, blah, 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 would you ask the ATP to bring for the eval to trial? And we have 20 minutes to answer all these. So I opened up the chat box so I can read it. So if you guys want to start typing in. K5, absolutely. There's no K6, but that's okay. Yeah, definitely a K5 because she's independent with all that stuff. What do you think for cushions? Rigid back, folding frame. Okay, yeah. So they do make K5s in folding frames. That is available. Obviously, they're going to be a little bit heavier. They're not as good as a rigid frame. Here's where I'm going to get all nerdy and physicsy. So that folding frame, because it has those cross members, you have extra attachment points. So that frame is going to have some movement in it, right? So you want a little bit of movement in a frame, but not as much as in a folding frame. So if there's somebody who maybe toward the end of the day is going to get a little bit tired, you want to try to push for that rigid frame chair, right? So all of that energy that they're putting into that wheel is going to, well, most of the energy that they're putting into that push is going to translate into those wheels. It's going to translate into propulsion. With a folding frame chair, because that frame moves a little bit, you're going to lose some of that energy. It's not a ton, but depending on the person, that could make the difference of them being exhausted at the end of the day and then coming home from work and being able to play with their kids at the end of the day. So that's one of those things. And again, it may be a transportation issue. Maybe they don't have the ability to get a rigid frame chair into their car. Maybe a folding frame is the best option for them. And maybe that transference of energy doesn't matter. So that's an option too. Rigid back, T9, T10, she could with no postural issues. I would sacrifice that rigid back for a sling back, just for weight. She doesn't have any postural issues. I would let her hang out with that sling for a little while, because that if she does start to develop a little bit of things, that's easy to change out. You can ask insurance for a new back, and you can put that on a little bit later. I would start off with that sling back, especially T9, T10. It's a little bit lower, so she's not going to have huge trunk stability issues. J cushion depends. Again, she's independent. If she's continent, like if she's not having incontinent issues, J makes a ton of different cushions. So gel, yeah, J2. I don't know that I put her on gel. I probably, again, unless if she's super bony, maybe. The issue with gel is that it's heavy. You got all that maintenance and stuff. If she could swing with foam, I'd probably go foam. But yeah. Contoured rigid for the back. again, a T9, T10, she's probably not going to be bad off. I don't know that she would probably need that contoured. Again, I'd probably stick with the sling back and see how she runs with that. Good. Anybody else? Okay, next one. A little bit harder. Hey, what happened? Okay. Oh, it was a long one. I shouldn't have written this so long. Now I have to read it. 68-year-old male with a CVA, left side hemiplegia, is in a sniff, approaching discharge, unable to self-propel, perform pressure relief independently, leans to the left shoulder sublux with pitting edema in the distal upper extremity, very thin and incontinent. While using a wheelchair in the facility, tended to slide down in the chair, causing a fall risk. He will be discharging to his daughter's home, where he will have main floor bedroom bathroom. What would be your recommendation? Tilt and spade. Wow. Man, you jump right on that one. Yeah, absolutely. Yeah, I didn't address the foot propel. In this one, I'm pretty sure I was leaning toward that tilt and spade, so I would say no on the foot propel. How about cushions? Gel. Yeah, definitely start there, gel. Just because he's incontinent and bony. Depending on how much the family is going to be into maintaining the cushion, the gel cushion, that would be a big part of it. Just to make sure that they're, every time he gets out of there, that they need that gel back into place. Lower left upper extremity support. Yep. So definitely an arm trough on that. With the edema, that hardware for the arm trough would need to be able to lift up to help with that, drain that fluid out from the hand. What else we got? Thoracic support. Yep, probably, definitely. For the thoracic support, I would probably do a thoracic lateral instead of a contoured back, just so you have that one point of contact. Because so the contoured backs tend to sit kind of lower, just under the pecs. That's usually where that curve sits. So you can get that thoracic lateral a little bit higher. You don't, because he leans on that left side, or watch where you put that lateral. You don't want that thing digging into his axilla. You're gonna end up with red spots doing that. But yeah, definitely a lateral. Chest straps, pivoting upper extremity supports. The pivoting, yes, you want a little bit of internal rotation on that. So yeah, that's a good one. For that sublux shoulder, because if he's got that thing straight and out, it's probably going to cause him a little bit of pain. So you want to bring that a little bit of internal rotation on that to help ease that pain. Chest straps, if he has a tendency to fall forward, yeah, we definitely do chest straps. Let's see what else I was thinking about on this one. The tendency to slide down in the chair. What can we use for that? A couple different options. Not a pummel. Don't you dare type pummel. 4-point, yeah. You probably get away with just a 2-point laid over the right in front of the ASIS. You can also do an anti-thrust cushion. They're okay. You got to watch out for those, because you could, if they push really hard into that ledge, you could end up with some IT skin issues, especially with him being bony. Definitely do, if you're going to do a 2-point belt, definitely make it padded, since he is bony. You don't want ASIS skin issues. Footrests, shoe straps. Maybe if that left leg has a tendency to fall off that foot plate, then yeah. Could be a calf panel in the back, just to keep it back there. May not need a whole shoe holder, but yeah, definitely something to keep that foot from kicking back, especially if you're tilting them. You need something to keep that foot on the plate so it doesn't drop off. Yep, good one. All right, let's do the next one. So I did a class for COTA students from Middle Georgia University, and I did this, and I totally forgot what I was even thinking when I wrote it. So we may have to work through this one together. So, 15-year-old male CP, spastic quad, verbally communicates his need, but speaking triggers his tone. Power chair user since 7, recently outgrown his current setup. Metaval shows slightly flexible pelvic obliquity. Left side's higher than the right. Flexible posterior pelvic tilt, fixed scoliosis, and flexible hip adduction. Starting to develop skin issues to his right IT and right ribs. Some possible solutions. I'll let you guys go, and then maybe I'll chime in. I should have wrote notes about what I was thinking when I wrote this, because I don't remember what I was thinking. All right. Contour cushion. So a custom cushion. Yeah, definitely. The flexible obliquity, so you can build up that right side, or build up that right side to try to level that out. Flexible posterior pelvic tilt. What can we get for that? How about a belt? 2-point belt, that pelvic tilt. The fixed scoliosis, that's going to be the problem, right? So that the skin issues to the right ribs is going to be from that scoliosis. So your best bet is probably going to be maybe a foam in place. If you can get that foam to wrap around a little bit, that would be ideal. If not, very, very well padded, probably with a gel insert for a thoracic lateral on that side. Since he's fixed, you want to try to make sure that he can keep his head as upright as possible to be able to drive, to be able to see where he's going. Yeah, the fixed scoliosis is always an issue. Because he's 15, I wouldn't do molded, because he's probably going to grow out of it. And since he ages out at 21, that's probably when you're going to want to do your mold for that scoliosis. The hip adduction, what do we got for that? We're almost there. 6 more minutes, and you can go to bed. Yeah, medial thigh support. Yep. Awesome. All right. So some resources real quick. RESNA, they're the governing bodies for ATP and SMS. ATP, since we're at the end of it, let me tell you what an ATP is. ATP is Assistive Technologies Professional. So that credentialing is for any assistive technologies. It's not just for seating. The SMS is Seating Mobility Specialist, which hopefully I'll be sitting for soon. Permobile, so they are awesome for resources. They have these little seating guides for seating and positioning, kind of troubleshooting guides. I handed those things out like candy. But you can go, they have PDFs now that you can download. So if you're interested in any of this stuff, definitely go check those out. They're super helpful. Houston Methodist, like I said, is on New Motion's website. If you really want to, if you want to get into this, you want to start doing seating evals, go pick up Michelle Lang's and Gene Mickles' Seating and Wheel Mobility textbook. It's got everything you could ever want to know. Mine is actually right here somewhere. Aha. So that's it. That's what it looks like. Go get it. Mine hardly ever leaves my side. So any questions? You got 4 minutes. No, nothing. Thanks, Kristen. All right, so that's it. I appreciate everybody that actually showed up at 8 o'clock at night to view this live. Thanks.
It was
Gave me somebody to talk to.
definitely worth it, Bryan. It's
Awesome.
not my wheelhouse, but I was attending the whole thing. So I know who to call.
All right.
Especially your great rationale for power chairs for children, because if they're not moving, their vestibular system isn't. They don't know where they are. So great.
Yeah.
Thank you.
Yeah. Oh, I stand on my soapbox for a while on that one. That drives me crazy.
Wow.
Yeah, everybody, remember to fill out the eval on the website so you get your CEUs. Now that you know all this, I know there's a lot of information really quick. Hopefully you guys all got the handout so you can review this stuff. If you guys have any questions, that's my email address, beclever.atp@gmail.com. It'll probably take me a couple of days to see it. So if it's anything urgent, you can shoot me an email at my FODAC. Or if you need equipment for somebody that they can't get it through other means, my other shameless plug, it's just my name, Bryan Clever, no space, no dot, no nothing, at FODAC, FODAC.org. So yeah, get out there, get some people moving.
Thank you so much. Good night, everyone.